All right, let's jump right in. We're going to tackle a classic medical showdown, ITP versus TTP. Now, both of these conditions give you dangerously low platelets, but they're completely different beasts. To really get why they're so different, we've got to first do a super quick rundown of how your body plugs a hole when you start bleeding.
So, primary hemostasis, it's like a three-step emergency response. First gear is adhesion. Platelets literally just stick to the site of the injury. Bam. Second gear, activation. They don't just sit there. They change shape, get angry, and start screaming for help by releasing signals. And the final gear, aggregation. All their buddies rush in and clump together, forming a temporary plug. Adhesion, activation, aggregation. Sounds pretty smooth, right? Well, what happens when these gears grind to a halt? That's when things get serious. And this is exactly where our story splits into two totally different pathways. Think of it like this. On one hand, you've got ITP. I like to call this the immune heist. It's an inside job where your own immune system starts hunting down and destroying your platelets. Then you have TTP, which is more like a mechanical grinder. It's a physical process that just chews up and spits out your blood cells. A heist versus a grinder? See? Worlds apart. So here we are at the fork in the road. Picture this. A patient shows up, low platelets are confirmed, and now you have to make a choice. One patient, two possible paths, and only one crucial test to guide you. And let me tell you, making the wrong turn here can be catastrophic. And what is that one make or break test? It all comes down to a single question you ask when you look at the peripheral blood smear. Are there schistocytes? You know, those jagged, ripped-up fragments of red blood cells. The answer to that question, yes or no, is the whole ballgame. It literally determines every single thing you do next. All right, let's explore path 1. We've looked at the smear, and the answer is no. It's clean. No schistocytes in sight. This path leads us right to the scene of our immune heist, a case of isolated thrombocytopenia. So what does this patient look like? Typically, they're young, maybe came in with some weird bruising or tiny red dots on their skin called petechia. You check their labs, and their platelets are in the basement, maybe 20,000. But here's the kicker, and this is so important. Everything else is normal. Red cells, fine. White cells, fine. The blood cell factory, the bone marrow, is pumping out product like a champ. The problem isn't production. It's that once the platelets hit the streets, they're getting taken out by the immune system.
So what's actually happening here? Well, the core problem is that your body has made a terrible mistake. It's created antibodies that are specifically targeting a receptor on your platelets called GPIIb/IIIa. Think of it like putting a big "kick me" sign on the back of every platelet. The spleen sees that sign and just gobbles them up. It's a total case of friendly fire.
Okay, so for your exams, here's the money slide. What's the next best step for ITP? It's actually a pretty clean algorithm. You just look at the platelet count. If it's over 30,000 and the person isn't bleeding all over the place, you just watch and wait, observe. But if that count dips below 30,000, that's your trigger. You got to step in and calm down that rogue immune system, and your first line weapon is steroids. That's it. Simple, right?
Okay, let's rewind. We're back at that fork in the road, but this time we're taking the other path, path 2. And this is the emergency. This is where the smear is an absolute disaster zone, and you've just walked into what we call the lethal Pentad trap.
The second you see low platelets plus any of these other red flags, you have to completely erase ITP from your mind. We're talking about a patient who's not just bruising. They have a fever, they're confused or acting strangely, and their kidneys are taking a hit. You'll see that as a rising creatinine. And of course, the blood smear is littered with those schistocytes. This isn't an isolated problem anymore. This is a full-blown, body-wide catastrophe.
Let me say this as clearly as I possibly can. This is a medical emergency. The diagnosis is thrombotic thrombocytopenic purpura, TTP, and it is an absolute emergency. Every single second counts. You don't have time to wait around for confirmatory tests. This is a clinical diagnosis you have to make fast because this patient is on the brink.
So, what causes this whole train wreck? Believe it or not, this entire disaster comes down to one tiny thing, a faulty enzyme. It's called ADAMTS13. The easiest way to think about it is as a pair of molecular scissors. Its whole job, its only job, is to snip these long, super sticky protein strands called von Willebrand factor into smaller, bite-sized pieces. So here's the TTP cascade step by step. 1. Your ADAMTS13 scissors are gone. They're either missing or something's blocking them. 2. Without the scissors, these huge uncut strands of von Willebrand factor just build up everywhere. They're like sticky spider webs flowing through your blood vessels. 3. These webs are perfect platelet traps. Platelets get caught, they start clumping, and you form thousands of tiny clots, microthrombi, in your small blood vessels. And finally, step 4. Red blood cells trying to get through this mess are forced to squeeze past these clots, and they get shredded in the process. And that is where your schistocytes come from. It's mechanical carnage.
So, what's the move? What's the next best step? There is only one right answer here, especially on an exam: plasmapheresis. And you do it immediately. You are literally washing the patient's blood, taking out the bad stuff, like the antibodies attacking ADAM-TS13, and putting in good plasma that's full of fresh, working enzyme. It's a rescue mission, and it has to happen now.
And I have to give you this one critical life-saving warning. Your first instinct when you see a low platelet count might be, hey, let's give some platelets. Do not do it. In TTP, that is the worst thing you could possibly do. It's literally like throwing gasoline on a fire. All you're doing is giving those sticky VWF webs more logs to build bigger, more dangerous clots. You will make things worse. So never give platelets.
All right, let's bring it all home. We've seen the heist, we've seen the emergency. Now it's time for the final showdown. Let's lock in this logic so you never mix these two up again.
Here it is, side by side, ITP versus TTP. Let's run through the high points. Smear finding? Clean in ITP, full of schistocytes in TTP. The core problem? Rogue antibodies in ITP, missing scissors, ADAM-TS13 in TTP. Key symptoms? Isolated bruising in ITP, that scary lethal Pentad in TTP. And the most important part, the next best step? For ITP, you observe or give steroids. For TTP, it's plasmapheresis, no questions asked. This table is your cheat sheet.
Okay, pop quiz time. Let's see if this is cemented in your brain. Scenario 1. You've got a patient with low platelets and absolutely nothing else wrong. All other labs are perfect. What's your diagnosis?
You got it. That's ITP. The I stands for immune, but you can also think of it as isolated. All right, next one. Low platelets again, but this time, the smear is full of schistocytes and the patient isn't making any sense. What are you thinking now?
TTP! And your brain should be screaming emergency. Time to move fast.
Last one for the road. What's the name of those molecular scissors that go missing in TTP? The key enzyme?
ADAM-TS13. That's the one. It's the villain at the heart of the whole TTP story.
So there you have it. You've totally nailed the logic that separates these two critical platelet problems. But here's the thing. That initial platelet plug, that's just a temporary fix. It's like putting up sandbags against a flood. To really win the battle, your body has to call in the heavy artillery, the entire coagulation cascade, to build a rock-solid fibrin fortress. So, the primary plug is secured, but are you ready for the fibrin war?